Now we will discuss about male infertility, the basics of spermatogenesis. You can see the structure of seminiferous tubule, the gut section. Near the lumen you have the mature spermatocyte, and in the stroma you have the different phases of immature spermatocyte. And this entire process from the primordial germ cell to the mature sperm, it takes 71 days, and this transport from the lumen to the epididymis to the ejaculatory duct takes 21 days. This is governed by Y chromosome. Hormone regulation, you can see FSH acts on Sertoli cells to promote spermatogenesis. Also FSH acts on the Leydig cell to promote Leydig cell receptors, LH receptors. LH acts on the Leydig cell to produce testosterone. Hypogonadotrophic hypogonadism. So if it has happened before puberty, there is no FSH and no testosterone. No testosterone means no spermatogenesis, and no FSH means there is no quality in sperms. So before puberty, if there is hypogonadotrophic hypogonadism, the external supplementation of testosterone is insufficient to initiate spermatogenesis. But if it has happened after puberty, where the Leydig cell has already got exposure to FSH to promote this LH receptor, then your external supplementation of the testosterone can help to maintain the spermatogenesis which has already been initiated. The normal testosterone production is 5 to 10 milligram per day, and the concentration of testosterone is 50 to 100 times more in the testes than in the blood. Effects of aging. There are chromosomal abnormalities, DNA fragmentation and point mutation. Birth defects are common. Serum total testosterone falls by 0.4% and the free testosterone falls by 1.3%, and this is called androgen deficiency in male, ADAN or andropause. Clinically, you can have osteopenia, decreased muscle mass, testicular atrophy, gynecomastia, decreased libido, decreased stamina, cognition disturbances, etc. Much of male infertility is idiopathic, reflecting our still very poor understanding of the mechanism that govern the testicular function. This is a classification on the causes for male factor infertility. Idiopathic accounts for 40 to 50% cases, gonadal reasons is 40%, and the hypothalamic causes only 1 to 2%, obstruction accounts for 20%, or the disorders of sperm transport. First one is hypothalamic causes, decreased GnRH. Normally, the olfactory neurons communicate with the mitral cells, and the axons of which pass via the olfactory tract to reach the hypothalamus. The GnRH secreting neurons uses this pathway to ascend and reach the hypothalamus. This process is under the influence of anosmin-1, which is produced by CAL1 gene. In a patient with CAL1, CAL2 or prokinetin 2 and prokinetin 2 receptor mutation, the anosmin is absent, so the olfactory neurons are unable to communicate with the mitral cells. So the GnRH secreting neurons stays here, it is not able to reach to the hypothalamus. So the patient will have sexual infantilism, anosmia, red-green color blindness, neurosensory hearing loss, synkinesis and midline facial defect, also renal agenesis. Other causes for GnRH deficiency or the drugs that inhibit the secretion, or the tumor that inhibits the delivery, or the critical illness, head injury. Moving to the next cause, primary gonadal disorders. It is contributed by many factors like Klinefelters, abnormal chromosomes, etc. So the first one is Klinefelters. It is 46XXY. This extra X chromosome is not a problem here. What is the problem is the testis determining gene is translocated from this Y to the X. When this gene goes to X, it is inactivated and it is not able to express its activity. So there is no spermatogenesis. There are increased CAG repeats in the androgen receptor gene. The patients will have increased FSH and LH and low testosterone. The sperm count is low, they appear intervitalized, they have cryptorchidism, poor judgment, poor attention span, cognition defects, and they have small and firm testes with damage in both the seminiferous tubules and the Leydig cells, and they have risk to develop pulmonary disease, CA breast, varicose veins, mediastinal germ cell tumors, SLE, and diabetes. Abnormal chromosome 46XY and 45X or similar to Turner syndrome, they have streak testes and they have the risk for gonadoblastoma development. So you need to do gonadectomy. Y-chrome microdeletion. In the long arm of the Y chromosome, you have a region YQ11 that codes for genes DDX3Y, BSPQY genes. It will cause azoospermia and oligospermia. Proximal, middle, and distal regions in the azoospermia factor genes. This Y chromosome microdeletion should be tested before doing ICSI, because if the deletion is not diagnosed before ICSI conception, it will be passed on to the male offsprings. Single gene mutation and polymorphism. Single gene mutation, normally androgen is essential for the differentiation of spermatids and its release from the seminiferous epithelium. So any mutation in the androgen receptor gene, that is increased CAG repeats, can cause infertility. And also the estrogen receptor gene polymorphism like DAEZL, PRM12, TNP1, TNP2, ESP26 can also cause infertility. Cryptorchidism. Cryptorchidism is the presence of testis elsewhere. So the process by which we bring it back into the scrotum can help to restore the normal testosterone production, but the probability of conception and the return of the semen value, normal parameters of semen depends on the duration it has been exposed outside the scrotum. Post surgery, they have had increased FSH and decreased sperm density, they are having the risk for infertility. Varicocele, you can see the spermatic veins left and right. The left has very straight course and long course. It joins the renal vein at right angle, so it has a problem of stasis, hypoxia, and accumulation of toxic products that damages the spermatogenesis. But this is only theoretical, and association with infertility is still not established. Infections, you can see TB can cause damage to the epididymis and cause obstruction. Mumps can cause damage to the germinal epithelium. Drugs, cyclophosphamide, chlorambucil, flutamide, cyproterone, spironolactone, ketoconazole, cimetidine, all these can cause gonadal failure. Radiation exposure 0.015 gyre will suppress spermatogenesis, whereas exposure to 6 gyre will cause permanent azoospermia. Gonadotoxins, heat, stroke, metals, pesticides, all can affect the testis. Smoking, marijuana, cocaine can also affect the sperm quality. Moving to the next disorder of sperm transport. Isolated asthenospermia is presumed to result from epididymal dysfunction. 1 to 2% of the infertile men and 6% men with obstructive azoospermia have CBAVD or CFTR gene mutation. Cartagena syndrome is primary ciliary dyskinesia, have recurrent sinusitis, pulmonary infections, bronchiectasis, situs inversus, and oligoasthenospermia. Young syndrome patients have inspissated secretions in the vas and epididymis. Evaluation. What are the goals of evaluation? We have to identify the specific cause. If the cause is correctable, correct it. Treat the underlying medical condition. If the cause could not be identified, corrected, find out who are the candidates for IUI and do IUI. Find out who need ART, TESE or ICSI conception and do that, and find out the candidates who need donor sperms and give that. What are the points in history? We ask the duration of infertility, coital history, childhood illness, occupation hazards, and drug abuse, previous treatment history. Previous surgical history is very important because inguinal hernia repair and renal transplant or scrotal surgery can cause unrecognized injury to the vas deferens, and the retroperitoneal surgeries can disrupt the neural pathways leading to ejaculatory dysfunction. Patients having alpha blockers like methyl-dopa, guanethidine, they can have ejaculatory failure. Physical examination, you can see the presence and position of the urethral meatus in the penis, palpate the testis, measure the volume, and palpate the vas and epididymis, the presence and consistency, note varicocele, note the secondary sexual characters, and do a rectal examination to note the size of the prostate. Semen analysis. Semen analysis is the initial evaluation. If it is found abnormal, another semen analysis should be done at least after 4 weeks. The candidates are advised abstinence for 2 to 3 days because if the patient has gone for a longer period of abstinence, it will increase the volume and density, and it also increases the dead and immotile abnormal sperm, so resulting in variation in the reports. They have to masturbate into the container in a private room within or nearby the lab, and it should be transported in a room temperature, should be examined within 1 hour of collection. This is the normal reference values. Volume is 1.5 to 5 ml, pH is alkaline, sperm concentration is more than 20 million, sperm number is more than 40 million per ejaculate, motility more than 50, morphology more than 50, round cells less than 5 million. We call it abnormal when the sperm concentration is low, motility is less, and the morphology is less. This is the lower reference limits with recent update. The semen volume, previously it was 1.5, now it is 1.4. The sperm number is the same. Motility is increased. It was 40 initially, now it is 42. Progressive motility was previously 32, now it is 30. The normal forms is the same, 4, 4. First parameter, volume. Majority of volume comes from the seminal vesicle, which share a common embryology with the vas deferens. Reduced volume means there is problem in emission or collection or short abstinence or obstruction in the ejaculatory duct or hypogonadism or retrograde ejaculation. Whenever the volume is less than 1 ml, you can do a post ejaculatory urine analysis to detect the retrograde ejaculation. Concentration. The absence of sperms should be documented on at least 2 separate occasions, and it should be examined in a 400 times magnification. Azoospermia can be obstructive or non-obstructive. Obstructive causes are congenital bilateral absence of vas deferens, previous inguinal surgery and trauma. Non-obstructive causes are primary and secondary testicular failure. We call it oligospermia when the sperm count is less than 20 million per ml, and it is considered severe if it is less than 5 million per ml. When it is severe, they need endocrine evaluation. Motility. The forward progression is graded from 0 to 4, rapid, slow and non-progressive. This grade 2 to 4 is considered as total progressive motility, that is purposeful forward motility. The increasing the motility to up to 60% will raise the probability of conception. Asthenospermia means there is a problem in the testicular and epididymal function or the presence of autoantibodies, genital tract infection, WBCs in the sperm, semen, partial obstruction of the ejaculatory duct, varicocele, prolonged abstinence interval or Cartagena syndrome. Morphology. Severe tetraspermia is an indication for ICSI. Morphology remains the best available predictor of sperm function, that is the capacity to fertilize a mature oocyte. Human zona binding assay, it detects the ability of the sperm to penetrate the zona. It is done in vitro. CASA is computer assisted semen analysis, it gives a accurate and precise value of the motility and the concentration. Acrosome reaction, decreased acrosome reactivity in response to treatment with calcium ionophore points to infertility. Sperm creatine phosphokinase is a biochemical test that is done. WBCs will produce reactive oxygen species that will damage the membranes. The lipid peroxidation happens. Fatty acid peroxide is toxic to the structure and it releases the enzyme inside, that is sperm creatine phosphokinase. Sperm chromatin structure DNA fragmentation test can be done. Endocrine evaluation is done if the sperm concentration is less than 10 million or the patient has sexual dysfunction like decreased libido and erectile dysfunction. Urologic evaluation includes thorough clinical physical examination if it is not done already, and genetic evaluation is done to rule out Y chromosome microdeletion or 47XXY. So, in endocrine evaluation, step 1, you measure the FSH and total testosterone. If the total testosterone is less than 300 nanogram per deciliter, you have to repeat it. Is still persistently low, then you measure the free testosterone. Free testosterone less than 5, then measure LH and prolactin. If FSH is low and testosterone is also low, that means it is hypogonadotrophic hypogonadism. If FSH is high and the testosterone is low, that is hypergonadotrophic hypogonadism. If prolactin is high, it is hyperprolactinemic hypogonadism. CBAVD is diagnosed by physical examination alone. It does not require a sonography or exploration. Testicular volume on palpation, soft small testes indicate testicular failure. Normal volume of the testis is 15 to 25 ml. When the testicular volume is normal, but the ejaculation product has low volume, then you can do a transrectal ultrasound to detect the ejaculatory duct obstruction. In a patient with proven azoospermia with high FSH, there is no need for testicular biopsy. Testicular biopsy is done when testis appears normal and has at least one palpable vas difference and the FSH is normal. The testicular biopsy that we take the tissue is stored for ICSI in future. We come for the treatment. Since majority of the cases are idiopathic, first treatment is nothing is effective. Nothing, androgen, FSH, tamoxifen you can try, but nothing is effective. Hypogonadotrophic hypogonadism. So, they have low GnRH or low gonadotropins. So, you can give a pulsatile infusion pump or HCG injections. Majority of the cases are associated with prolactinomas. So, bromocriptine and cabergoline can be helpful in them. Eugonadotrophic hypogonadism can be treated with anastrozole and testosterone. Hypergonadotrophic hypogonadism indicates testicular failure and they need ICSI. Retrograde ejaculation is treated with sympathomimetics that acts on the internal sphincter. Leukocytospermia can be treated with antibiotics, but the treatment will not improve the semen parameters. Surgical treatment. The options available are vasovasectomy, epididymostomy, transurethral resection of ejaculatory duct. This transurethral resection of ejaculatory duct will restore the semen volume in 2/3 of the patient and return the sperms to ejaculate in 1/2 of the azoospermic method. Since only palpable varicocele have a documented association with infertility, the other means of diagnosis, like if it is only documented in ultrasonography, it does not need a varicocele repair. But if for a palpable varicocele, if repair is done, it offers a permanent cure and natural conception. Young men with a large varicocele and infertility of short duration are the ideal candidates. If the patient has had atrophic testis or increased FSH, they are poor they have poor prognosis after repair. Orchiopexy, at the least, it will preserves the testicular hormone production. Vibratory stimulation and electrical ejaculation can be applied for ejaculatory failures. A small word on intrauterine insemination. Intrauterine insemination is better than intracervical insemination. The fecundity rate is 3 to 10% if the partner's sperm is used, if they found to be infertile, and the fecundity is 9 to 30% if the IUI is done with donor sperms. The prognostic factors, the best results are achieved when the number of total motile sperm exceeds the threshold of approximately 10 million and the morphology is more than 14%. Normal means they have higher success rate. Maternal age less than 35 have good prognosis. Absence of tubal factors will improve the success of IUI. The sperm preparation, we have 3 methods: so conventional sperm washing, spin up technique, and density gradient centrifugation. In conventional washing, what they do is they put a medium and the semen in a ratio of 1:1 or 1:3, and they do centrifugation. Remove the supernatant, those at the bottom will be taken. But this has a problem: the dead sperms will not be removed. It is the conventional sperm washing. In swim up technique, what they do is they mix it with the buffer, put the centrifugation, remove the supernatant, but the final pellet is subjected to incubation at 37 degrees Celsius for 30 to 60 minutes. The motile sperms will come up, but the non-motile sperms will stay down. So this part is taken and used for IUI. So the number of sperms is reduced, but the quality of the sperm is better than the conventional sperm washing in this swim up technique. Density gradient centrifugation is where there is an overlay of the liquefied ejaculator on the column of high density media. The centrifugation is done for 15 to 20 minutes, and the sperms with the highest mobility will be in the bottom. This is taken and it is used for IUI. The timing, it should coincide with the spontaneous or induced ovulation. Sperms can survive for 3 days, but the ovum will be fertilized on only for 12 to 14 hours after its release. Cryopreservation damages the sperm, and if the IUI is done after ovulation induction after HCG injection, it should be done after 34 to 40 hours. These are the other methods of sperm retrieval: epididymal sperm aspiration, testicular sperm extraction, and testicular sperm aspiration. This will be discussed in the next video. Thank you.